Can you guys hear me?
We hear you, but we can't see you.
All right. And now you see the presentation, or?
Okay, here we are.
All right. Thank you for having me. So we're gonna touch upon a very important topic, which, when we are doing all these clip cases, is a lot of time we leave with residual TR. These can be very difficult cases, and sometimes we cannot abolish the TR, and we need to know what is the clinical implication of leaving these residual TR. So if you look at the prevalence among the three major trials, if you look at the triluminate trial, you see that at baseline you had 97% had severe to massive torrential tricuspid regurgitation. 52% of the cases ended up with trace and mild, around 38% with moderate, and 10% remained severe, massive, or torrential. For the Pascal trial, around the same thing, 42% with mild, 13% with none, 32% with moderate, and 11% with severe, and some left with massive TR as well. And in the BRIGHT registry, also you can see that there was significant, around 50% had more than moderate residual TR. So we see this is not a perfect procedure, and probably patient selection, case selection is extremely important. And if you look at also different registry, and if we want to look at 2+ and 3+, it goes anywhere from 10 to 20%. And the only one who had no major residual TR was a TRISCEND 2 trial, because this is a tricuspid replacement. So in replacement, you can go down to 0 TR, but that's not the case. For example, in triluminate, the tricuspid FR registry, the Pascal registry, the BRIGHT, and the EuroTR. So that's very important to see that we leave these patients with significant TR and no less than 10 to 20%. And how does it impact survival? So in this trial from Stolz and European Heart Journal of Heart Failure, he followed the patient who had residual less than 2 and residual TR more than 3. And if you look at 30 days, 50% of the people with significant residual TR had a 50% 2-year survival versus 74% for the people with residual TR less than 2%. So this is the first signal that you can affect mortality if you leave a lot of TR. Okay, there's a lot of confounding factor, but leaving the table with more than 3+ TR is not good for the patient. And that's from the mortality standpoint. What about symptoms? And if you look at the change, this is the change in New York Class Association. And if we go from no TR reduction to more than 3-grade reduction, the change in New York Heart Class Association was gone from 40 to 63%. So people feel better when you decrease more their TR. So that's impact on heart failure symptoms. And if we look at the quality on life and functional capacity, also it's very important. This is a trial from Sawaya, from Minneapolis group. And if you look at the quality of improvement, if you have more than 2-grade reduction, the quality of life improves, versus if you live with severe TR or no change, your quality of life worsens. And this goes as well also for the 6-minute walk test. And if you have a significant TR reduction, more than 2 grades, you have a 25-point change in your 6-minute walk test. So also very important to know that. And not only this, we look at symptoms, we also look at RV remodeling. If you look at the RV unloading, which is the reduction in your RV and diastolic volume, if you leave with the residual more than 3+, you have actually an increase in volume of 4%. And if you leave with residual less than 1, 18% reduction in your end diastolic volume. And this goes the same for the right ventricular end systolic volume, which also, if you leave with residual, your end systolic volume will leave. So the function and the volume of the RV is very poor. And if we want to ask, what do we predict by the residual TR? So you have multiple studies, but usually the worse the TR at the beginning, it will predict residual TR. If we have a big gap size, we're going to have residual TR. The leaflet anatomy, we have 4 or 5 leaflets. Like a previous speaker showed, this showed that it's going to be more difficult to close. Jet location, if it's in the posteroseptal, it's more difficult than your enteroseptal. If you have a huge RV, a huge RA, sometimes it makes it more difficult. Having a pacemaker lead is always challenging in these cases. The lead TR is always the most challenging. Of course, imaging quality. If you don't have a good TE imaging, sometimes we rely on ice, because if you don't have good imaging, you cannot do a proper grasping. Also, if you have very dense chordae, especially in the commissures, this makes sometimes the cases more difficult. And also, if the annulus is extremely dilated, that's never a good case for a tear. You probably need replacement. And there's one score called the GLIDE score that predicts some of these TR reductions. So if you look at the septolateral gap, if it's more than 6 millimeter in the posteroseptal, it's usually not great. If you have multiple jets, not only in enteroseptal, which usually has the high success, makes it that you add more points. If the imaging quality is poor, it adds another point. If you have very dense chordae, that adds another point. And of course, the shape of the annulus. And then you look at the GLIDE score. If the GLIDE score is very high, that's probably not a good patient to tackle. So in conclusion, we need to try to leave the lowest TR possible, because residual TR impacts mortality, it impacts symptoms, it impacts quality of life, impacts RV remodeling. And I feel the future is going to be, if we have a good enteroseptal leaflet and the jet is in the enteroseptal, this is probably a good TR case. But for all the others, it's probably going to be a replacement device with a low pacemaker rate. Thank you.
Dr. Sawaya, thank you very much for your excellent talk. I have just a couple of questions. First of all is, if you realize during the procedure that you have a 3+ TR, how do you deal with this? And second, what is the percentage of these patients with residual TR that are referred for surgery?
Yeah, I mean, usually you can't do anything acutely. You try to spend as much possible time to get the low TR, but sometimes it's not possible. Sometimes you create deformation in these valves, so you can't really correct it. And you have 2 options after. You can either, I've had cases where residual was high, either you refer to surgery, but the majority of these patients, are rejected, they're sick, they come late, and they don't want to do tricuspid valve replacement. The other thing you can add after is a trick valve. So I've done like failed tricuspid triclip, and then you end up putting the trick valve, where you put an SVC valve, IVC valve, just to decrease the risk of right-sided heart failure symptoms. But I mean, I never took off the patient table, directly sent him to surgery. You need to reassess him and decide.
Professor, let us get a little bit from your experience. You add a ring, you see the valve, and you are not happy. First of all, I want to emphasize that it's wrong that we're a little bit more lenient to the tricuspid compared to the mitral. 1+, 2+, it's okay. It's nice that you show that it's not okay. The only thing that's okay in these 2 valves is the 0, even trace. The more, it's harmful to the patient. But let's suppose you try this repair, and at the end you are not that happy. Would you entertain an edge-to-edge stitch, or do you use any different techniques to complete the repair except the ring?
No, honestly, if you end up putting clips, we don't, I'm not a surgeon, I'm an interventionalist, so I don't do the surgery. The other thing you can do is annular reduction, but all these devices, they're really complex, and they're falling, we're not using them anymore. Now the next step is using tricuspid replacement. But definitely, if the repair is not good, you have to send them to surgery. If your TriClip is not a good, or the Pascal device, you have to send them to surgery eventually. Like you said, the data is the data. Residual TR is not good, and we're very lenient in leaving these moderate plus, and we're happy, but at the end of the day, the patient is not doing well on the long run.
Thank you very much. We'll proceed. Thank you very much. We'll proceed to the next speaker.